All right, team, welcome. 6 o'clock, we have a quorum of attendees and presenters present. Still waiting on one more, but we can go and get started. Can everyone hear me? All right, I have some microphones on from the attendees. Can everyone hear?
Yes.
Yes.
All right, excellent. Now, I want to make sure you can see my screen. All right, beautiful, you can. So I'm just going to start with a little introduction, myself and our special guests and some of the concepts. So first and foremost, we have a very special guest, Dr. Maureen Kohi. Thank you so much for being here. UCSF IR Chief and recently published this paper, which we'll be going over today. So it's such an honor to have you here, Dr. Kohi.
Thank you so much. Such an honor to be here.
Let's see, this is actually a collaborative webinar journal club between the Women in IR Committee and the GIG Repro Service Line. So we have some good information here for you. I'll start off with a little background on medical management and surgical management of uterine fibroids, but the bulk of today's session will be on uterine fibroid embolization. So we'll go ahead and get started. A lot of my concepts come from this nice review straight from our OB-GYN colleagues on the evidence-based management of uterine fibroids. So we'll start with the medical management here. A lot of the medical management focuses on this hypothalamic pituitary ovarian axis. A lot of the medical management is hormonal, but not all of them. We'll go over the hormonal and non-hormonal treatments and also the surgical options. So we'll start with medroxyprogesterone acetate, the Depo-Provera intramuscular injection. This has a prolonged duration of action since it is released slowly from the muscle. It does have multiple mechanisms of action, but basically it inhibits ovulation. And the use of it for treating uterine fibroids is actually observational. About 20 women in this study by Venkatachalam, but the use of Depo-Provera did show reduced uterine and fibroid volumes in 6 months, increase in hemoglobin. This is for patients who are having like abnormal uterine bleeding or menorrhagia. And with the use of Depo-Provera, menstrual loss was reduced. This is tranexamic acid. This is a non-hormonal treatment, an antifibrinolytic. Basically, it inactivates the plasminogen activator in the endometrium, and it's useful for achieving hemostasis. Studies have showed that this tranexamic acid can reduce menstrual loss, and it can also induce necrosis of the fibroids. Here we have mifepristone. This is progesterone blocker, it's an anti-progestin, and multiple studies have shown that it can reduce menstrual loss, it can improve fibroid-associated symptoms, it can, but however, it can cause hot flushes for our patients. So something to think about is when we're using any kind of treatments is what kind of side effects our patients will be enduring with the treatments. Further studies have shown uterine volume reduction, 27 to 49%, and also myoma size reduction, 26 to 74%. Again, in this study by Steinauer, we see hot flushes are one of the side effects that our patients can have. Let's see, moving on to the intrauterine system. Now, this intrauterine system are those that release progestogen hormones. Kind of different from the intrauterine devices, which are usually associated with this copper IUDs, but these intrauterine systems are the progestogen releasing systems. There's about 11 studies, at least 11, in this review by Dr. Zheng, and it shows that patients who use this intrauterine system have reduced menstrual loss, increased hemoglobin, increased ferritin, and decreased uterine volume. Some of the studies, though, did show that although there's reduced menstrual loss, there was increased hemoglobin, the use of these intrauterine systems had no effect on fibroid volume. So that's something to be aware of. What we're treating here, does our patient have bulk symptoms or bleeding symptoms? We'll keep it moving. Next is our gonadotropin releasing hormone analogs. An example of this would be leuprolide. These are designed to interact with the GnRH receptor. They modify the release of pituitary gonadotropins such as FSH or LSH. These also can improve hemoglobin levels. They can reduce uterine and fibroid volume by about 50%. Moving on, we have these selective estrogen modulators. Specifically, we're going to focus on raloxifene here. These SIR-RFS, selective estrogen modulators, they can selectively inhibit or stimulate estrogen actions in various tissues. But this medication, raloxifene, is anti-estrogenic specifically in the uterus. And since fibroids and estrogen have a relationship, this is aimed at addressing that. Raloxifene has been shown to have no change in fibroid volume, but also no new fibroids that come about during treatment. However, it has no effect on pelvic symptoms, menstrual blood loss, or hemoglobin level. These are some of the newer medications that are out. This ulipristal acetate, selective progesterone receptor modulator, SPERMs. These aim to lower or block progesterone with the intention of shrinking fibroids. And we have multiple studies now, randomized control trials, PEARL 1, PEARL 2, PEARL 3 trials that do show decrease in the volume of fibroids, decrease in menstrual blood loss. And if we take a look at these percentages, they're pretty high. Looking at this slide here, the PEARL 3, they utilized up to 4 courses of this selective progesterone receptor modulator, this ulipristal. And by the 4th course, the 3 largest fibroids in these patients shrunk by about 75%, and patients were amenorrheic. That was the goal here, amenorrheic 90% of the time after the 4th courses. We also have aromatase inhibitors. These block aromatase, which converts androgens to estrogens, and these also are associated with hot flushes. The studies that were reviewed here did not show relief of any fibroid symptoms, however. We have some growing data on MRI-guided focused ultrasound. This is where we have a focused ultrasound that are able to ablate fibroids. 3 studies that were reviewed is that about 91.5% of patients reported satisfaction and reduction in fibroid-related symptoms, but this study only had 54 patients. Another study reported about 21 to 28% of women need further re-intervention after focused ultrasound surgery. And last but not least, it was deemed to be safe, a safe option for patients. Last but not least, the surgical interventions. For patients who have submucosal fibroids, hysteroscopic resection is the gold standard. Otherwise, laparoscopic is preferred to open myomectomy. Patients who undergo laparoscopic have lower post-op pain, less post-operative fever and shorter hospital stays, and less bleeding. So it makes sense to aim towards laparoscopic if you're going the surgical route rather than open myomectomy. And last but not least, what you've all been waiting for, uterine fibroid embolization. So that was a rapid fire approach. We'll move on to Peyton here. Peyton, I'm giving you full power of the screen.
Can you hear me?
Yeah, we can hear you.
All right. And is my screen showing?
Not yet. Just make sure to click show screen or share screen. Got him.
Good?
You are good.
Alrighty. So my name is Peyton Kramer. I'm a third-year medical student at the McGovern Medical School in Houston, Texas. Tonight I'm going to be discussing a review article called Updates on Uterine Artery Embolization that was written by our very own Dr. Kohi here with us tonight in conjunction with Dr. Spies. Before getting started, I just wanted to take a moment and thank Dr. Kohi for providing me with early access to this article. It was actually just recently hot off the press, published in Seminars in Interventional Radiology. This review is going to discuss the uterine artery embolization for managing symptomatic uterine fibroids with a special focus on the emerging technical approaches and novel peri-procedural patient care. So with that, let's get started. So uterine fibroids, also known as leiomyomas, these are the most common benign neoplasms of the female pelvis, with a lifetime prevalence exceeding 80% among African American women and approaching 70% among Caucasian women. Approximately 50% of women with fibroids are going to experience symptoms at some point, and hysterectomy does remain the most common treatment option for fibroids. However, concerns have been raised about the overuse of this procedure. Uterine artery embolization was first reported by Ravina et al. In 1995 as an alternative therapy to these surgical interventions that's both uterine preserving and minimally invasive. So most interventional radiologists are going to prefer to see these patients for an initial clinic consultation to determine whether they're candidates for this procedure. And during this initial clinic visit, they're going to review their history, including symptoms, age, prior fibroid therapies, their preferences regarding uterine sparing therapies, their desire for future pregnancy, as well as assessing their procedural risk factors. The most common indications for this procedure is going to be menorrhagia or heavier prolonged menstrual bleeding, dysmenorrhea or severe menstrual cramping, the pelvic pressure, discomfort, bloating, fullness or bothersome distortion, dyspareunia or pain during intercourse, urinary urgency, frequency, nocturia, or retention. As far as contraindications go, there are very few absolute contraindications, but these include having a viable pregnancy, active infection, suspected malignancy. And while not contraindications, there are some other conditions that certainly require special caution, including having a severe contrast allergy, renal impairment, and coagulopathy. Symptomatic postmenopausal women should always raise a red flag for some kind of endometrial malignancy or hyperplasia. However, after ruling out these more severe pathologies and confirming that the fibroids really are the source of their symptoms, then embolization is certainly appropriate and has been shown to improve bulk-related symptoms in these postmenopausal women by 88 to 92%. Another controversial topic, it was previously thought that embolizing patients with an IUD in place increased the rates of infection. You have this foreign body in the uterine cavity in conjunction with this necrotic tissue. It was thought that this was kind of like a nidus for infection. However, a large follow-up study of women showed that the risk for pelvic inflammatory disease was actually less than 1 in 1,300 in women with IUDs. So as of now, IUD is certainly not a contraindication. So reviewing recent fibroid imaging is extremely important prior to going on with this procedure. While most patients will likely have had a pelvic ultrasound, a contrast-enhanced MRI has been shown to be more accurate, as demonstrated by this case. So this was a 44-year-old woman who presented with menorrhagia. And this pelvic ultrasound demonstrated a large intramural uterine lesion that was thought to represent a fibroid. However, with further imaging, she got a contrast-enhanced T1 MRI, and this showed that the lesion in question actually was focal adenomyosis. It wasn't the fibroid as suspected. So MRIs with contrast has become the preferred method for assessing the uterus and pelvis because of the ability to thoroughly look at the location of the fibroid and look at enhancement characteristics, really get a good understanding of the arterial supply, and clarify other pathologies that may mimic fibroid symptoms, such as adenomyosis, as seen on the right image, and I'm going to talk about that a little bit further later on. And then also helping to detect leiomyosarcoma, which is an extremely rare but significant malignancy. So adenomyosis, this is characterized by the diffuse or local growth of endometrial tissue within the muscular layer of the uterus, with a prevalence of 5 to 70% among women between the ages of 30 and 50. This disease predominantly affects the posterior uterine wall, resulting in diffuse uterine enlargement, widening of the junctional zone, and often coexists with fibroids and presents very similarly, as far as symptoms go, to fibroids. The presence of adenomyosis is not a contraindication to embolization, and in fact, uterine artery embolization has been shown to result in clinical and symptomatic improvement for patients with isolated adenomyosis. Long-term relief may range from 64 to 82%, and the outcomes really depend on the extent and vascularity of the adenomyosis, the degree of necrosis, and the presence and absence of fibroids. And better outcomes have been demonstrated in cases of adenomyosis with lower T2 signals, focal areas, and using smaller particles for embolization. So traditionally, this procedure is performed with moderate sedation via right common femoral artery approach with embolizing the uterine arteries bilaterally. Some alternative approaches, so the bilateral femoral access allows shorter procedural and fluoroscopy time. Also, recently, transradial access has gained popularity because it allows patients to freely move following the procedure and assume more comfortable positioning. However, with this method, it is important to recognize that some technical modifications have to be made because of the extensive distance between the wrist and the uterine arteries. So procedural success is always going to rely on having a really good understanding and imaging of the vasculature supplying the fibroid itself. So while most patients are going to have a bilateral uterine artery supplying the fibroid, a small subset of patients are going to present with a purely unilateral arterial supply. And it's important to recognize these patients because unilateral embolization shows similar results to bilateral embolization in this particular subset of patients. In addition, the authors of that study showed that unilateral embolization is associated with shortened fluoroscopy time and improved post-procedural pain. So these patients really can benefit from just doing a unilateral embolization if this is recognized and confirmed that there is only unilateral supply. In cases where the fibroid is predominantly supplied by the ovarian artery can be catheterized, embolized, just like the standard uterine artery procedure. Common belief is that this procedure would result in ovarian failure. However, the data provided by a study done by Hugh et al. Actually contradicts this. They reviewed several cases of direct ovarian artery embolization, and their results implied that treatment did not precipitate the onset of menopause, nor did it increase menopausal symptom severity. Something else to look out for when assessing the vasculature is to look for the anastomosis between the uterine arteries and the ovarian arteries. These have been attributed to causing treatment failure and also cases of permanent amenorrhea and ovarian dysfunction. Ravasi et al. Described 3 types of anastomosis described below, but recognizing these are important to enhance clinical success and prevent non-target embolization. However, there really isn't much evidence proving that a particular type of anastomosis puts patients at greater risk for treatment failure or ovarian dysfunction. And more importantly, in determining ovarian function over the long term is likely the age of the patient rather than the presence or type of these anastomosis. Something else that needs to be taken into consideration in these patients are the size and shape of their fibroids. So for some time, the procedure was not recommended for patients with fibroids greater than 10 centimeters, especially those located in the submucosal area. And the reasoning behind this was from a few case reports that resulted in infection, uterine injury, sepsis, and even death with these larger fibroids. However, the more recent years, several reports have demonstrated safety and efficacy in fibroids much larger than 10 centimeters and in patients with a megauterus, which is just when the volume is beyond 1,600 milliliters. So as far as shape of the fibroids, another previous contraindication or relative contraindication was fibroids that were pedunculated, and this was because of the theoretical risk for stalk necrosis causing subsequent bowel or peritoneal inflammation. However, multiple studies again have shown that this procedure is safe as long as the stalk diameters are greater than approximately 2 centimeters. So based on the current evidence, safety isn't a concern. Something that should be taken into consideration, though, is these pedunculated fibroids are less likely to infarct than those seated deeper in the uterine wall. So the efficacy might not be as great, but as far as safety concerns, pedunculation is certainly not a contraindication at this time. And we kind of touched on the GnRH agonist prior to this, but just to expand on this a little bit further, so this induces a hypoestrogenic state. And by doing this, because the fibroids are hormonally driven, you're able to reduce the volume of the fibroids by 30 to 50% and improve symptoms within 3 to 6 months. However, by inducing this low estrogen state, women frequently experience the menopausal symptoms. And using this prior to uterine artery embolization has been kind of controversial because although you can reduce the size and maybe improve the success of the embolization, some studies have shown that using this prior actually decreases the uterine vasculature and therefore would make the embolization less efficacious. So further studies are needed to actually get a good understanding of the utility of these agents prior to embolization. As far as pain management, while only 30% of patients are going to experience pain during the actual procedure, greater than 90% of women are going to report pain after the procedure. So that's really where we're focused. And the types of pain that these patients are experiencing are kind of classified in 2 different categories. So the first is the immediate pain that's thought to be due to ischemia related, and this is going to occur within hours of the procedure. Whereas the other type of pain is due to this general inflammatory response characterized by fever, nausea, malaise, and this can last up to a few days, up to 72 hours. So in treating this immediate ischemia-induced pain, therapy that's been studied is the superior hypogastric nerve block. This has been shown to be particularly useful in the first 4 hours in treating that ischemia-related pain. And by entering the anterior abdomen, you can inject some ropivacaine at the 5th lumbar vertebral body, and this has been shown to reduce opioid use and as well as antiemetics. In treating this big inflammatory response, steroids and lidocaine have been studied. Just a single dose of dexamethasone prior to the procedure reduces pain scores, and then using a lidocaine injection after the procedure has been shown to improve pain scores. And it's important that the lidocaine is after the procedure because lidocaine causes severe vasospasm, and if it's done before the procedure, it can limit treatment efficacy because you get the incomplete necrosis. So the lidocaine has to be done afterwards. And the expected clinical outcomes following this procedure include a 50 to 60% reduction in fibroid size, a 40 to 50% reduction in uterine size, an 88 to 92% reduction of the bulk symptoms, a greater than 90% elimination of abnormal uterine bleeding. And compared to the other surgical alternatives that were discussed a while ago, they have similar patient satisfaction rates with shorter hospital lengths of stay. However, there are higher rates of minor complications and higher likelihood of reintervention within 2 to 5 years. Particularly at 3-year follow-up, the average reintervention rate is about 14%. So post-procedure fertility, little is really known about the effects of how this procedure is going to affect fertility and future pregnancies. My colleague Megan's going to talk to you all about this topic, so I'm not going to dwell on it too much. But the current line of thought is that myomectomy has better reproductive outcomes than embolization. However, this conclusion is based on just this one prospective randomized controlled trial with several limitations. In contrast, a recent trial showed that annual fertility rates were similar in both the embolization groups and the myomectomy groups. So, at this point, we really don't have a clear understanding of how these surgeries compare, and I think Megan's going to talk to you all about that. Complications associated with this procedure include permanent amenorrhea, and as you can see, this is much more likely in women over the age of 45. Prolonged vaginal discharge, fibroid expulsion, which can result in ascending infections, sepsis, pulmonary embolism, non-target embolization. Less common complications include infection, delayed contrast reactions, UTIs, urinary retention, nerve or vessel injury at the access site, and less than 1% of patients are going to require a hysterectomy because of the complications from this procedure. And 3 fatalities have been reported, resulting from a PE, sepsis from pyometrium, and ovarian cancer. And that is all I have. If there's any questions, we can use this chat box or we can open up to discussion at this time. And then I also have 3 quick little poll everywhere questions. If we want to move on to that, just let me know.
I think we can save that till the end, and we'll test the short-term, long-term memory. All right, Megan, thank you for being here, Megan. I'm going to give you full power access.
Can y'all hear me? I just wanted to chime in here. I'm so sorry. I just wanted to chime in here and tell you guys how incredibly proud I am to just witness everything that you have put together. This is such high-level education. I have learned so much, and you should all be very proud of yourselves. This is high-level, state-of-the-art, like cutting-edge. The amount of work that you must have put into this is truly commendable, and I wish that when I was a trainee, a medical student, or even a resident, that I had access to such material, because it really does teach a great deal about the field of fibroids and women's health and all the different options that go along. So thank you so much.
Wow, awesome. Thank you, Dr. Kohi.
Thank you.
Thank you.
So,
yeah, go ahead, Megan. It's all you.
Can y'all see my full screen? Let's see.
Yes, perfect. Yes, we can see the full screen.
Awesome. So my name is Megan Clark, and I'm a 4th-year medical student at WVU, and this is a paper on the midterm clinical and first reproductive results of a randomized controlled trial comparing uterine fibroid embolization and myomectomy. So the importance of this is that uterine artery embolization is a well-established treatment for symptomatic fibroids in women who do not plan on becoming pregnant in the future. However, its role in women with reproductive plans with symptomatic fibroids remains pretty controversial, and like Peyton said, little is known about it. And surgical myomectomy is currently the standard of care in this population. This is the first prospective randomized controlled study comparing the 2 treatment paradigms in this cohort. So infertility following UAE has been documented in previous literature and is theorized to be due to non-target embolization of the ovaries and endometrium. It is particularly difficult to study infertility in women who have had UAE because of confounding factors such as age. So this population they tend to be a little bit older and or later in their reproductive years because that's when fibroids become symptomatic. And then also the presence of fibroids themselves are associated with reduced infertility or reduced fertility. So this study, initially 149 women with uterine fibroids were, and unfinished reproductive plans were evaluated from November of 2001 to December of 2005. 21 patients initially refused to participate, and 7 were excluded based on the criteria of the study. They initially underwent a pretty extensive workup, including a gynecological exam, abdominal and transvaginal ultrasounds, including Doppler of the uterus and fibroids themselves. Their serum levels of FSH, LH, estradiol were all measured on the 3rd day of their menstrual cycle, and pelvic MRIs were performed in some patients, specifically when the clinical exam or ultrasound was suspicious for adenomyosis or sarcoma, in virgins where transvaginal ultrasound was impossible, and in all patients after April of 2004. Additionally, all patients were asked to fill out a questionnaire that got a little more information on their fibroid symptoms. And then they were randomly selected for either UAE or myomectomy. So this is the inclusion and exclusion criteria for completeness. We don't have to go over it. The study population, it was pretty homogeneous between the 2 groups, with the exception of sterility. There was a statistically significant difference between the 2 groups, and there were 11 patients in the embolization group and 24 in the myomectomy group. I also wanted to point out that 51 patients, or 42% of the all the patients participating in the study, had additional subfertility factors. So this is a table comparing the 2 groups and their pre-procedure ultrasound imaging. You can see here that there is no difference between the 2 groups and their fibroids. So for the embolizations, all the procedures were performed by the same interventional radiologist. Every patient got a single dose of antibiotics 30 minutes before their procedure, and everyone underwent a bilateral uterine artery embolization by the right common femoral artery, and the embolization material was embospheres. Aggressive pain management within the first 24 hours was pursued with either epidural anesthesia or continuous IV infusion of opioids, and they didn't remark on their decisions regarding either one. And nausea and post-embolization discomfort was subsequently treated with antiemetics, NSAIDs, and acetaminophen. And the minimum length of stay for the embolization in this trial was 48 hours. The embolization was deemed a technical success when it led to bilateral occlusion of ascending branches of the uterine arteries and complete loss of fibroid perfusion. The authors defined peri-procedural complications of this group as dissection or spasm of the uterine arteries, drug reaction, hematoma in the groin, or other complications of angiography. So in the myomectomy group, the same 2 surgeons performed all operations. They also had a single dose of antibiotics prior to the procedure, and their operations began with a hysteroscopy to evaluate for submucosal fibroids, which would eliminate the patient from the study. They performed an open myomectomy if the patient had a fibroid that was greater than 8 centimeters, had multiple intramural fibroids, or was in a very unfavorable location per the surgeon. And then they performed a laparoscopic myomectomy in all other patients. So the myomectomy group received the same postoperative pain and symptom management as the embolization group. The minimum length of stay for the open myomectomy was 5 days, and for the laparoscopic myomectomy was 48 hours. The technical success, the procedures were deemed technical successes when all detectable fibroids greater than 4 centimeters were completely removed, and the authors defined perioperative complications in this group as injury of organs in the abdomen or pelvis and or to injury to major pelvic vessels, blood loss exceeding 1,000 milliliters, unexpected penetration of the uterine cavity, unplanned conversion from laparoscopic to open myomectomy, and early reoperation due to uterine bleeding, hemoperitoneum, or hematoma. So this is an exhaustive list of the early complications that were defined by the authors, and that was complications that occurred between day 1 and day 30 after the procedure. And this is an exhaustive list of the late complications defined by the authors, and that is anything after the first 30 days. So patients were closely monitored throughout the entire study, but they had planned follow-ups at 1 month, 6 months, and then subsequently every 6 months after that. The exams included a physical exam and an ultrasound exam, and at 6 months, the FSH, LH, and estradiol levels on the 3rd day of the menstrual cycle was obtained. And for those women who had elevated FSH at 6 months, their FSH was continually monitored. And the myoma symptom questionnaire was re-administered again at 6 months. So all patients were advised to wait to try to conceive until after their imaging results of the 6 month follow-up were obtained. So absence of fibroid greater than 5 centimeters or fibroids deforming the uterine cavity, and absence of hematoma or thickening of the myometrium in place of previous myomectomy were seen as favorable findings on ultrasound with respect to planned gravidity. And MRI was redone in patients who either had one prior to their uterine artery embolization, or if their ultrasound showed no reduction of fibroid burden. And that was basically to confirm that the fibroid still had sustained perfusion, and that essentially that it was a failed embolization. So reinterventions in this study means myomectomy. That was the only reintervention that occurred in this study. And myomectomy was recommended in the case of undetectable fibroid shrinkage at 6 months following UAE, or a fibroid that persisted to be greater than 5 centimeters after UAE, and then any recurrence of a fibroid either after UAE or myomectomy. And for those who got reinterventions or myomectomies, they were also advised to wait another 6 months before they tried to become pregnant. So women with previous history of infertility and favorable outcomes on follow-up imaging at 6 months were referred to a fertility specialist to undergo causal infertility treatment. And reproductive attempts and results were recorded at regular 6-month checkups. Additionally, perinatal monitoring and delivery was offered to all the patients in this study. So the results of this trial were analyzed on an intent to treat basis, and 120 completed through the 6-month follow-up, and 118 were remaining through the 12-month follow-up, which is actually pretty impressive. So this is a graph of the peri-procedural results, and we can see here that the technical success rates were about the same between the two procedures, and but the average time for UAE was significantly less than the myomectomy. And this is a graph of the early post-procedural results, and we can see that in line with pretty much all other literature, the average hospital stay, recovery period, and disability was significantly less in the UAE group compared to the myomectomy group, and the complications were pretty much the same in both groups. This is a graph of late post-procedural results, and or a table, sorry. We can see that the relief of symptoms in UAE and myomectomy, there was no statistically significant difference between the two, and they also, again, had no difference in complication rate. However, in the UAE group, there was statistically significant elevations or elevations of FSH above 10 in comparison to the myomectomy group. And most impressively, the re-intervention rate in this group was about 10 times that at the myomectomy group. And as a reminder, all re-interventions got myomectomies. So the persistence of a fibroid greater than 5 centimeters was the most common indication for re-intervention. So of the 19 patients in the embolization group that required a re-intervention, 15 were due to the persistence of a fibroid, and 5 of those were patients that were initially documented as technical failures. And re-intervention was indicated in 4 cases for clinically significant recurrent fibroid. And then in the myomectomy group, the only indication for re-intervention was clinically significant recurrence. So for complications in the late post-procedure results, there were no serious or life-threatening complications in either group. In the embolization group, there were 4 complications related to ovarian function. 8 women had FSH levels greater than 10 at 6 months, 4 of which had pre-procedure FSH levels greater than 10. And there were 2 cases of decreased libido, both of which resolved by 12 months. And in the myomectomy group, there were 2 women that had FSH levels greater than 10 at 6 months, and 1 of which had a pre-procedure FSH of greater than 10. So for the reproductive results, in the embolization group, 26 out of 58 women tried to conceive, which is 44%, compared to the myomectomy group, where 40% of the 63 women who had a myomectomy tried to conceive, which is statistically significantly different than the embolization group at 63%. For the embolization group, 13 of the 26 women who tried to become pregnant, only 13 of the 26 women who tried to become pregnant actually became pregnant, for a pregnancy rate of 50%, in comparison to 31 out of the 40 in the myomectomy group, for a pregnancy rate of 78%. The delivery rate in the embolization group was 19, and the delivery rate in the myomectomy group was 48, which is also statistically significantly different. The abortion rate in the embolization group was 64%, and compared to 23% in the myomectomy group. And additionally, the mean interval between procedure and gravidity in the embolization group was 18 compared to 13 in the myomectomy group. So this is a figure comparing the reproductive results of the UAE versus myomectomy. The UAE is represented on the left in the white bars, and the myomectomy is on the right in the gray bars. I just wanted to draw your attention to the delivery and abortion differences. So interestingly, for the perinatal results, we can see that there's no statistically significant difference between the 2 groups, and that of note, the women who received UAE who made it to the 2nd trimester, none of them had any pregnancy-related complications repeatedly described in other trials, such as gestational hypertension, fetal growth retardation, malpresentation, or prematurity. So, reproductive results could be influenced by the short duration of follow-up and unequal number of patients who tried to conceive in each group. That was statistically significantly different, 26 in the embolization group versus 40 in the myomectomy group. And the re-intervention rate was higher in the embolization group, which means they had less time to get pregnant in that 2-year follow-up period. And the difference observed in the successful deliveries and the abortion rates definitely favor myomectomies, and this study doesn't really give us any answers as to why. Is it an error due to small numbers? Is it a reflection of the influence of UAEs on ovarian function, or its influence on uterine perfusion, or blastocyst implantation, or uterine cavity and the endometrium? We don't really know why or anything about the like the differences between these two groups and why this happens in these patients. So, like we've all said, very little is known about the impact of UAE on fertility, and at this time, this is the only prospective randomized controlled trial comparing UAE to myomectomy for the treatment of symptomatic fibroids in patients with future pregnancy plans. And future studies should also look at the etiology of subfertility in patients treated with UAE versus myomectomy, because that could give us a little insight as to whether or not the procedure is, you know, the root of their post-procedural infertility or not. And that is all. My questions are here, so we can save these till the end.
Awesome. Thank you, Megan. Dr. Kohi, would you like to share any thoughts on that presentation?
Well, first, again, I just wanted to applaud all of you. This is an incredible, amount of work that was put in. I think that, if you want to, I'm happy to comment on the challenges that we face when we see patients and we counsel patients, and also when we discuss this procedure with our referring clinicians, such as gynecologists. But maybe there's some questions lurking around. I don't want to just jump in without you guys, saying, without you guys deciding. I just wanted to tell you this was the most complete. People don't need to go to SIR. I think they just need to see this webinar, and it's the most complete presentation of fibroids and management I have heard ever. So again, congratulations.
Well, I do see a number of our attendees do have questions. Perhaps we'll let Sarah do her presentation, and then maybe she might answer some of those, and then we'll open it up to all questions. So Sarah, I'm going to go ahead and give you full presenter power, and if you could share your expertise with us, then we can get to the attendees' questions as well. I want to respect their time and their questions. All right, Sarah, your mic is on.
Can you see my screen?
Yes, we can. Well, it's loading now.
Okay. Okay, can you see it? Let me know when to start.
You're good to go if you can.
Okay, so my name is Sarah Khan. I'm going to be presenting an article on the current evidence. Hold on 1 second. Share my screen.
Nice. There you go. You're on. We can see your screen.
I know.
Nice.
Okay.
Thank you.
So I'm going to be presenting the current evidence for uterine embolization for fibroids. I am a PGY5 in radiology at UCLA, and I will be starting fellowship at UCLA this July. This is the article that I'm going to be presenting. It's by Dr. James Spies from Georgetown, and it was published in the Seminars for Interventional Radiology in 2013. And it's basically just going to be a review of the literature that was available until it was published. So the article focuses on a few main questions. Does uterine embolization relieve symptoms caused by uterine fibroids? Oops, sorry, I'm screen again. How well does the improvement in symptoms and quality of life compare with standard surgical treatments? And how durable is the improvement in fibroid related symptoms and quality of life after embolization? So a little bit of background: fibroids are benign muscular tumors of the uterus. The incidence is over 50% at age 50, and a large number of patients seek treatment for symptoms. The three main groups of symptoms are heavy menstrual bleeding, pelvic pain, and bulk symptoms such as pressure, bloating, and urinary symptoms. The prevalence of heavy menstrual bleeding is about 84.5%, of pelvic pain is about 62%, and bulk symptoms is about 83.9%. And heavy menstrual bleeding is the dominant symptom in 65.4% of patients, pelvic pain in about 10.5%, and bulk symptoms in 23.3%. So there are several studies that have looked at symptom control after uterine fibroid embolization. I've just listed 4 of the studies with the largest number of patients. So Hutchins studied 305 patients and followed up these patients at 12 months. At 3 months, they found that 86% of patients had controlled menorrhagia symptoms, and keep losing my. And 64% had controlled bulk symptoms at 12 months, 92% had controlled menorrhagia symptoms, and 64% had controlled bulk symptoms. SPIES in 2001 studied 200 patients and followed them for 21 months, and they found at 3 months, 87% had improved menorrhagia, 93% had improved bulk symptoms. At 12 months, 90% had symptom control, and 10.5% of these patients required repeat gynecologic interventions and rehospitalizations. And Walker et al. Studied 400 patients and followed them for 16.7 months and reported 84% had improved menstrual bleeding and 79% had improved menstrual pain. And Prone studied 550 patients, followed them for 8 months, and found 83% had improved menorrhagia symptoms, 77% had improved dysmenorrhea, and 86% had improved urinary frequency. So the Fibroid Registry was a multi-center registry which was founded in 1999 with 72 enrolling sites, including academic and private practices. And it was a collaboration between SIR and the Duke Clinical Research Institute. They collected prospective data on short-term and long-term outcomes in UFE patients, and they measured symptom severity, change in symptoms, adverse events, health-related quality of life for up to 3 years after the therapy. They used a self-administered validated questionnaire, the Uterine Fibroid Symptom and Quality of Life questionnaire, and the primary outcome measure was the symptom score. Lower symptoms meant that they were less severe. Lower scores correlated with less severe symptoms, and the range was 0 to 100. And this is just like a brief look at the outcomes. So normal patients with no fibroids had a symptom score of around 15. Baseline symptom score in patients with fibroids prior to UFE was about 59.8. And then 6 months after embolization, the score dropped to about 19.8. So pretty close to what it would have been for patients without fibroids. And that was continued at 12 months, at 2 years, and 3 years. So there's some non-randomized comparative studies that I'm going to talk about. They basically compare, you want to compare fibroid embolization with other available standard surgical treatments. So hysterectomy was traditionally the primary therapy for symptomatic fibroids. Myomectomy has kind of been in favor to preserve fertility, and newer therapies such as laparoscopic uterine artery ligation. There's few trials about that, and at the time of publishing this article in 2013, there really wasn't much data on MR-guided focus ultrasound. So a few studies that looked at fibroid embolization and myomectomy. Broder et al. In 2002, they compared 51 patients who underwent fibroid embolization and 30 patients who had myomectomy. And at 3 to 5 year follow-up, they found similar symptom relief for both, an additional intervention rate of 29% for fibroid embolization and less 3% for myomectomy. And Siskin et al. In 2000 similarly studied 77 patients with fibroid embolization and 69 who had myomectomy. They found a reduction in symptoms of 88% for fibroid embolization and 75% for myomectomy, and an adverse event rate of 26% for fibroid embolization and 42% for myomectomy, and that was statistically significant. Other studies that have looked at hysterectomy, so SPIES in 2010, compared 107 fibroid embolization patients with 106 hysterectomy patients, 61 myomectomy patients, and 101 normal patients. They found the normal patient symptom score was again 15.3, and then the pre-therapy score was 64, so patients with fibroids. And 6-month follow-up, there was no change in the patients who didn't have any fibroids to begin with, not surprising. And then for fibroid embolization, the symptom score dropped to 24.9. Myomectomy, it dropped to 23.4, and for hysterectomy was the most improvement, down to 7.6. And similar results were seen for quality of life. In 2004, another similar study with 102 embolization patients and 50 hysterectomy patients. The hysterectomy patients had better pain relief at 12 months, but more complications. And at 3 years follow-up, 8% of the UP patients required reintervention, 88% had continued symptom control. So one of the randomized control trials I want to talk about is the EMI trial. It stands for embolization versus hysterectomy trial. It's a large multi-center randomized control trial from the Netherlands with about 177 patients who were randomized. The early outcomes for fibroid embolization were faster recovery and faster return to work time. Hysterectomy patients had a greater degree of satisfaction with the outcome. And similarly for both were the complication rates, the symptom control, patient outcome, and quality of life. Outcomes at 2 years, 24% of embolization patients had a recurrence of symptoms which eventually led to hysterectomy, and there was noted to be a high technical failure rate of 18%. Another trial that I wanted to talk about was the REST trial, which is the randomized trial of embolization versus surgical treatment for fibroids. This was a multi-center study from the UK with 157 patients, and they were randomized 2-to-1, 106 embolization patients and 51 surgery. Surgery patients had 42 of them had hysterectomy and 9 had myomectomy. And the early outcomes for fibroid embolization here were faster recovery and less pain than the patients. At 12-month follow-up, there was similar improvement in health-related quality of life and levels of satisfaction. And at 32 months, the fibroid embolization patients had a higher likelihood of reintervention, and 50% of those reinterventions recurred in the first 12 months. There's another study in 2010 that was published that looked at 27 fibroid embolization patients and 30 hysterectomy patients. And here the fibroid embolization patients reported improved pressure symptoms, shorter length of hospital stay, and faster return to work time. Hysterectomy patients had improved menorrhagia symptoms, more post-procedural urinary stress incontinence, and more serious complications. And at 2-year follow-up, 19% of the fibroid embolization patients underwent additional interventions. Here are some studies that are looking at, they're randomized trials that look at fibroid embolization and myomectomy. So Mara et al. In 2006, 121 patients were randomized to fibroid embolization or myomectomy, and myomectomy was associated with a shorter hospital recovery and shorter hospital stay, but there was overall no difference in the complication rates or symptom control. Manionda et al. In 2012, this is the FUME study, fibroids of the uterus, myomectomy versus embolization from the UK. 163 patients were randomized to fibroid embolization or myomectomy, and at 12-month follow-up, they reported equal improvements in quality of life scores, but final mean symptoms scored favored myomectomy. In June et al. In 2012, from China reported fibroid embolization had less postoperative pain, shorter hospital stay, shorter overall recovery, and at 12 months, there are a great number of fibroid embolization patients would have recommended this procedure to their friends. So some of the long-term outcomes. So this is sort of a busy table, but the first study by SPIES looked at 209 patients for a duration of 5-year follow-up, and 73% of patients had symptom control. The hysterectomy rate was 13.7%, and the recurrence rate was 20%. The following studies sort of showed similar outcomes, and patients were followed from looks like 3 to about 10 years. The last study, Schurig, Moncler et al., with 380 patients, there was a 23% recurrence rate, which was cumulative at 10 years. And they essentially noted that if a patient didn't recur in the early years, and late recurrence was really unlikely, because in this population with the patients in their early to mid 40s, late recurrence is sort of limited by menopause. At the time, patients who are menopausal will have permanent relief from their fibroids anyway. And then just to touch on the longer term outcomes from the EMI and the REST trials. For the EMI trial, the hysterectomy rate was 28.4% and recurrence rate 35%. And for the REST trial, the hysterectomy rate was 10% and recurrence rate was 32%. For the EMI trial, the higher technical failure rate was the reason given for this hysterectomy rate and the recurrence rate, because 18% of patients failed to receive bilateral embolization during the procedure, so they attributed it to technical failure rate. And that's the end of my presentation.
Excellent, Sarah. Thank you so much. I think right now would be a good time, since we've just gone over so much info, to answer any questions from the audience. I see a couple already that are here in the question box. Let's see. Oh, here, by Emily Sturvis. When counseling patients on potential complications for UAE, how much discussion goes into counseling related to potential future fertility? I think that's something Dr. Kohi was about to talk about previously.
That's a really excellent question. I think it depends on the patient's age, and this was presented, but you know, it is really hard. The way I discuss it is that it's really difficult to have great evidence for fertility in a population of women who are older and also have fibroids and also have undergone therapy for fibroids. So these are things we call confounders, because as women age, their fertility declines. In addition, we know that fibroids also decline fertility. And lastly, we know that any kind of intervention on the uterus could potentially decrease fertility. So when you have all three things happening, it's really impossible to know, you know, which is it? Is it because the woman is 42 that she can't get pregnant? Or is it that she's 42 and she has 4 fibroids that we treated? And if we treated with UAE. So it's really hard to discuss this. What I do is it's a very patient-centric discussion, and I talk to the patient and talk out her desires and her choices, and a lot of it has to do with her age and also her fibroids. So for example, if I see a woman who's 25 years old, never been pregnant, but she absolutely wants to carry a baby, then I counsel her that, listen, according to the trial by Mara that was presented, the trial itself was flawed, and that some of the points were brought up. It's not a perfect trial, but it's the only prospective randomized control trial we have. Based on that body of evidence, the chances of her going on to having a perfectly normal pregnancy and delivery are higher if she chooses a myomectomy. Can she still have UAE and have a perfectly normal pregnancy and delivery? Absolutely. I just can't answer the percentages. Now this number, my robustness of that argument actually goes down if she's 45. So if she's 45 and she wants to get pregnant, then it's a little bit different than a 25-year-old. So I say, well, listen, the chances of you becoming pregnant on your own are lower at 45 than they would have been at 20 or 25. And on top of it, I'm about to do an intervention on your fibroids. So it's a big, long discussion. It can be very emotional, but I think that you name all the data, you present the data that was beautifully presented today, and you essentially leave it up to the patient, because there's really no contraindication. Fertility is not a contraindication, but it's definitely something that needs to be talked out, if that clarifies this.
Awesome. Thank you, Dr. Kohi. I see another question by Rena here. She's been waiting patiently. With ACOG taking the stand that uterine fibroid embolization is as good as hysterectomy in certain patients, why is uterine fibroid embo not used more? Is it due to popularization of myomectomy? Is it RVUs play a factor? Is it lack of patient or physician knowledge about it? Your opinion, Dr. Kohi?
That also is a great question. I think that it also depends. I think a lot of it depends on where the patients are seen. So, for example, at UCSF, we have a multidisciplinary comprehensive fibroid center. So the gynecologists see the patients and they offer them the various therapies, just like you had presented, the pharmacologic therapies, the surgical therapies, and then the minimally invasive and the non-invasive therapies. And then it really is the patient's choice. Now in the community, it's a little bit different. And so you find that it's true that in the United States, the number one indication for hysterectomy is fibroids. And we just talked about how great UAE is, additionally, how great other medications are. So there is a little bit of physician preference. You know, if you go see a physician and she says, listen, we just need to take your uterus out, I think some patients will just go along with that. Now, thankfully, in the world that we live in today, patients have access to internet and they look up their condition and they come across other minimally invasive therapies. And so it is not uncommon that I see patients who have been told, you need a hysterectomy, where, you know, they can easily get a myomectomy or a uterine artery embolization. So a part of it is physician preference, so the gynecologist preference to just do a hysterectomy. Another one is lack of awareness of this issue when it comes to the patients. And lastly, I think, you know, this is something that I'm very passionate about, but women's health oftentimes gets neglected. How many times do you see a commercial on TV about fibroids? You know, very rarely, but, you know, being like hypertension or diabetes or cholesterol, you know, those things get more bang for their buck on the news and in the media. So, yeah, there's a lot of lack of awareness that this condition exists, and there's lots of great therapies. And I think that's where, you know, these webinars are important, and also other teaching directly to patients. So patient-centered marketing is important as well. But those are the main challenges as to why UAE isn't mainstream. Now, having said that, I should tell you that the 10-year results of the EMI trial, which is what was presented, the midterm results were presented, comparison of UAE to hysterectomy came out, and the results were extremely good to a point where the Gynecologic Society now considers that any woman who's a candidate for surgery should also be counseled for UAE or UFE, which is really, really great for our field.
Wow, that is amazing. Awesome.
That's right.
Dr. Kohi, I see a few other questions here. Eric King is asking, in terms of using radial access for UAEs, have you seen any increased risk of stroke?
The literature reviews that have been presented and the evidence, and a lot of this evidence is out of the Mount Sinai group. So with Aaron Fishman, who's a dear friend and an incredible guy, is essentially unheard of. You know, we're seeing there in the cardiology literature, there's a lot more reports of that, or by that I mean like there's some few cases of that, so it's still very rare. I think the patient population is also different. You know, that if you do find strokes in the cardiology literature, you're dealing with patients who have had coronary artery disease, so they're somewhat more prone to atherosclerosis, or they're older, whereas for the most part, women with fibroids are younger and healthier. I think that the advantage of going transradial is that the patient can move around, and oftentimes there's quite a bit of pain, as was already discussed, and it's more comfortable to lie on your side or in the fetal position, whereas if you go transfemoral, you have to be supine or at least keep the groin that was accessed flat, so that makes the post-procedure recovery a little bit more challenging. Additionally, you can potentially discharge patients home the same day. So there's definitely a benefit of going radial. But I think that most of us who do radial artery access really believe, especially in the uterine artery embolization subgroup of patients, that it is extremely unlikely. You can never say never in medicine, and especially when you do procedures, but this comes as close to that as possible.
Wow. Amazing. I see another question asking about, do any practices still consider a narrow stalk subserosal fibroids a contraindication?
This used to be a big myth, and I certainly remember about a decade ago when I was in training that their thought was, listen, if the stalk, if the attachment of the pedunculated subserosal fibroid is, I don't know, less than 2 millimeters or 3 millimeters, once you do a UAE, it'll detach and it'll fall into the peritoneal cavity, and then it'll cause bowel obstructions or adhesions. But for the most part, that has been proven incorrect and sort of a myth, the same way that there's myths of you can't possibly do a UAE on a big uterus, or you shouldn't do a UAE on a patient who has an IUD. So we don't really, at this point, care too much about that, and we proceed, and nothing bad happens, thank God.
Awesome. Michael Bergen has a question. Michael, I saw your hand was raised. Trying to give him some mic access.
Hey, can you hear me?
Yes, we can hear you. Please, you have the stage.
No, I was just following up to the question about the risk of stroke from radial access. There's only been one case report out of Miami Vascular from risk of a stroke complication from transradial access, and it was in a non-fibroid case. So I was just answering the previous case. To add to that, yeah.
Thank you.
Okay.
Dr. Kohi, just a personal question of my own. I'm really fascinated by that ovarian artery embolization during the uterine artery embolizations with no early menopause. How do I make sense of this?
Yeah. So you mean if you see an ovarian artery during a uterine artery embolization?
Yeah.
Well, you have to know that the actual ovarian artery is patent. And so the anastomosis that is visualized between the uterine artery to the ovarian artery is just a secondary source of blood supply. When I was starting out, this is again, like almost a decade ago, I would go in and I would occlude that communication. I would coil it and shut it off. But I've learned that you don't really need to. There are communications that exist between the uterine artery and the ovarian artery. And from the literature, we know that if a woman is 45 years or older, the chances of her going into early menopause or ovarian dysfunction, about 10, 15 or so %. But I just want to remind everyone that that can also occur if you undergo a hysterectomy or a myomectomy. So in fact, one of the outcomes of a hysterectomy, one of the many outcomes, is early menopause. So those blood vessels exist whether you do a UAE or whether you cut the uterus out or whether you cut the fibroid out. So again, a lot of what we do in IR is with patients, right? So patient contact, patient interaction, managing the patient's expectations. So you wouldn't ever want to do a big surgery on a patient and say, listen, everything's going to be fine, nothing bad's going to happen, let's go. So of course that doesn't happen, right? So the surgeon sits and they talk about all sorts of things, before the procedure. And this is one of the things that you talk about, that listen, if I see this, communication, for the most part, I can block it. Or what I've learned to do is just to inject the particles really slowly so that the blood flows then to the fibroid, which gobbles them up as opposed to the ovary, knowing that the ovary has its own supply that's patent. But having said all of that, we just need to know that the ovaries become less and less functional and less robust as a woman ages. So if you're doing a UAE on a patient who's 50, then, you know, she has a higher chance of going into early menopause than a UAE on a patient who's 28. So again, a lot of this stuff is discussed in that consultation before the procedure.
Awesome. Awesome. Sarah, I see your microphone is still on, and Sarah had prepared some questions. I'm just going to launch those. Sarah, your microphone on. Are you able to see those questions, everyone?
My microphone is on. I'm not sure how do I change presenter or?
Oh yeah, let me take that. All right. Let me see. And then let me put the polls up. Oh, there's some polls are being asked already. Can everyone see the polls? The first question that Sarah had prepared was let me see it. What were the short-term conclusions from the fibroid registry? All right. All right, let's close the poll. And Sarah, are you able to see the results from the votes from the audience?
No.
It says 86% said fibroid symptoms are controlled. Let me see what they all say. All right, should be seen by everyone now.
Yes.
All right, cool. Sarah, do you want to explain any of these?
Yes, so the short-term outcomes essentially were that the fibroid symptoms were controlled by embolization. Symptom scores did decrease to nearly that of normal patients, and that the symptom scores remained consistently low at 2 and 3 years.
Got it. So all those are true.
They are all correct.
Excellent. All right, let me put on the next poll. Let's find it. All right, next one is this question, launch. All right. What were the main conclusions from the Emmy trial? So that poll is being distributed now. We are collecting responses. All right, let's see. Go ahead and share what we've got. Sarah, are you able to see the results?
Yes, I can. And again, the early outcomes for fibroid embolization were that there was faster recovery and faster return to work time. Hysterectomy patients did experience a greater degree of satisfaction with the outcome, and there was no significant difference between the complication rates, symptom control, the patient outcome, and quality of life.
Wow, fascinating. So these are all true again, Sarah?
Yep.
All right, okay, excellent. And last question here. Distributing the poll. All right, Sarah, can you see the results? What were the main conclusions from the REST trial?
So the REST trial, the main conclusions were that fibroid embolization patients had faster recovery and less pain than the surgical patients. At 12 months, there was similar improvement in health-related quality of life and levels of satisfaction. And at 32 months, fibroid embolization patients had a higher likelihood of reintervention.
Excellent, excellent. All right, Peyton, I have your microphone back on. And I have you as screen presenter if you want to share your questions, some thought-provoking questions for the audience.
Okay. Okay. We want to try the poll everywhere?
We can. Whatever you think is best. I think the most important thing is the thought-provoking question and an impactful response. Whether or not the poll works, that's secondary, to be honest.
Okay. So what is the preferred method for imaging fibroids prior to uterine artery embolization? We can either do the text or y'all can put your comments in. Or
Yeah, team, if you'd like to just hit the chat box. I'd like to just see a few responses on that. All right, Peyton, you want to share your thought process?
Yeah, the correct answer for this one is MRI with contrast. Nice. As seen in that, those two images, the MRI with contrast had a lot of benefits over the pelvic ultrasound.
Excellent.
All right. Next question. Which of the following is an absolute contraindication to uterine artery embolization? And
I'm not seeing too many responses. Just go ahead and educate.
Okay. And the correct answer for this one would be...
I see the answers, yes. Nice, good responses, everyone.
Yeah, good job. So the correct answer for this one would be malignancy. As we discussed, postmenopausal women and IUDs are no longer, contraindications, as well as coagulopathies are only a relative contraindication and that require special attention.
Excellent. Excellent work, Henry, Rocky, Eric, Kim. I see everyone doing some strong responses there. All right.
Okay, and then the last one, which of the following is not a recommended therapy for pain management in this procedure? So the superior hypogastric nerve block, pre-procedural dexamethasone, pre-procedural lidocaine, or post-procedural lidocaine. All right, and the answer to this one would be pre-procedural lidocaine. As we had discussed that if you give the lidocaine prior to the procedure, it can cause the vasospasm and limit your clinical efficacy.
But you can give it afterwards, though, post-procedural.
Right on, right on.
Excellent, excellent. Strong work. I see Corinne, excellent. Malika, Rena, strong work, everyone. All right, I think we have one more set of questions by Megan.
Yes, can everyone hear me?
Yes. And
awesome.
Yeah, I'm giving you presenter powers to share your screen.
So I don't know if it's possible to do the poll everywhere.
It is possible, but I think we're having good responses from this questions, and people are really participating, so we can just go on how we're doing now.
Okay, awesome. Well, wait, hold on. Sorry. So my first question is what is the recommended standard of care for treatment of symptomatic fibroids in women desiring pregnancy? Do we have any answers yet? Can I go ahead and...
Searching. I have a few answers, waiting for a couple more.
Okay. Well, so we can either do no intervention, surgical myomectomy, UAE or medical management?
Someone's answer is UFE always.
So the recommended standard of care is actually surgical myomectomy in patients who absolutely are prioritizing pregnancy. But like Dr. Kohi said, it's very patient specific and there has to be extensive discussion, but per the books right now, it's surgical myomectomy and women desiring pregnancy. So the next question is, in the early postoperative period, patients undergoing UAE versus myomectomy had significantly decreased. Oh, we've got some responses.
Oh, we're definitely getting responses.
Complications.
Nice, excellent.
Complications, hospital readmissions, febrile mortality, or recovery period. So recovery period is the correct answer. Good job.
Nice.
I think it was a solo.
Nina, Malika, Rocky, strong work.
Nice. Okay, last one. In the late post-procedure period, patients who underwent UAE versus myomectomy had significantly increased symptomatic relief, decreased complications, increased reinterventions, or increased FSH elevations. So this guy's fast, or girl is fast. The correct answer is increased reinterventions. And that was my final question for the evening.
All right, everyone.
Thank you all so much.
Thank you, everyone. Thank you, Dr. Kohi. Thank you, all the presenters. Strong work. I'm getting a lot of texts from my colleagues saying all the presenters were really excellent. So thank you, especially the medical students. The medical students specifically.
Well, thank you. We appreciate your support.
All right, everyone. If there's no further questions, thank you. We'll see you at the next webinar.
Sounds great. Have a great
night.
Thank you so
much. Bye.
Thank you.